Overcoming compassion fatigue and burnout in pediatric oncology nurses. As a nurse manager in a pediatric oncology unit, I've observed an increase in nurse dissatisfaction and burnout caused by compassion fatigue. This pervasive issue detrimentally affects unit morale, which ultimately compromises the quality of patient care. This project's aim is to implement targeted programs and interventions that promote staff well-being and safeguard the mental well-being of our employees, ensuring a healthier work environment for both staff and patients. Compassion fatigue is a negative emotional state that arises from work-related stressors and secondhand trauma associated with the declining condition of patients. This issue significantly affects the nursing community and patient care. Compassion satisfaction regarding patient care is a term used to describe the sense of fulfillment one receives after helping a patient through a difficult time. Pediatric oncology is a field of nursing where compassion fatigue over time may outweigh compassion satisfaction. Implementing effective interventions that address the emotional strain associated with patient loss is essential. Research to address compassion fatigue. Research led by Angie Blackwell, a clinical nurse specialist, was done at a hematology oncology hospital, the Children's Hospital of Orange County, California. The research focused on reducing compassion fatigue among its staff. The researcher examined how introducing employee health and wellness programs could mitigate compassion fatigue and enhance compassion satisfaction. This mitigation would lead to increased happiness and job gratification among its staff. A 28-bed hematology oncology unit was used in this study. The staff of this unit had undergone an extensive literature review to determine the best interventions to use in this study. The two interventions that would be used was Code Lavender and debriefing. So Code Lavender is supposed to be a supportive program that reduces employee stress and enhances mental well-being. A significant aspect of this program is the recognition of employee stress. This method of crisis intervention has been utilized in many different hospitals, and as the author said, it provides real-time psychological first aid. So say a nurse is going through significant stress during a time in the unit, they could call a Code Lavender, and then they would be taken to the Code Lavender room. And in this room, it's a designated space for employees who are undergoing work-related stress, and in this respite room, there might be drinks, different types of therapies, music, and someone to provide a listening ear. In this study, they had that dedicated room, and they had a recliner, essential oils, music, and stress-relieving material. The picture to the right actually shows a little baggie that they gave to all the employees to educate them about the room. The staff were also encouraged to participate in debriefings, which discuss factors about the case in the course of the patient's treatment. They were held 12 to 24 hours after a patient's death. During these debriefings, staff were allowed to discuss feelings together, and they could discuss coping mechanisms. However, during the study, they were unsuccessful in implementing this intervention due to time restraints. This study was both descriptive and qualitative. Nurses of the Hematology Oncology Unit were the participants in the study. Initially, there were 38 that participated in the pre-intervention questionnaire. After 12 months post-intervention, there were 18, and then at the 2.5-year mark, there were 11. Data was collected using the Professional Quality of Life Scale, a questionnaire that measures two key variables: compassion fatigue and compassion satisfaction. A participant is given a statement to rank never, sometimes, often, or very often. These surveys were emailed to the participants. How it is measured. Compassion satisfaction is assessed through 10 different statements that focus on the caregiving aspect of nursing. Conversely, compassion fatigue is evaluated by two different subtypes. burnout and secondary traumatic distress. Both burnout and secondary traumatic distress consisted of 10 statements that people would rank. The results are then rated as low, moderate, or high based on the scoring obtained. Below is just an example of what a statement would look like and how they would rate the result. So in the instance, I feel worn out because my work as a helper, they would rank as never, rarely, sometimes, often, and very often. Results qualitative. On this slide, we look at two different tables. Table 2 looks at the component scores of compassion fatigue and compares it from the baseline to the midpoint. It looked at 3 components. I like my work as a helper. My work makes me feel satisfied. I am proud of what I can do. And what we saw with this is that it increased in overall satisfaction from the baseline to the midpoint. However, on table 3, we see the full picture of the study. With compassion for satisfaction, from the baseline to the midpoint, we see that increase. However, at the post-intervention, we see a decrease in compassion satisfaction. In both burnout and secondary traumatic stress, we see a decrease initially, though it's not statistically significant, but we see an increase in the post-intervention. These findings suggest that while interventions may temporarily boost compassion satisfaction, they may not be enough to reduce burnout and secondary traumatic stress over time. And this could have been to the many confounding variables of this study. Another aspect of this study was the qualitative descriptive data. Nurses were asked to describe their personal experiences with Code Lavender and the respite room. Their feedback was recorded and analyzed to identify different patterns and to see how they really felt about the program. Some of the responses were quite positive. The lavender room has provided a quiet place for me to reflect or regain my calm, or it's a lovely room, nicely stocked and very inviting. There are also some negative responses. The room was sometimes locked or occupied by other staff. I wish we had enough staff to take a break when we needed. To the right, we have different pie charts which represent how nurses rated their experiences with Code Lavender. Responses included strongly agree, neither agree, or disagree. Overall, the responses were quite positive, either being strongly agree or agree. This data was important to collect because it provided intel into the thoughts and feelings of the program, and it brought a way to gain feedback for future improvements. There were multiple pitfalls in the study. First of all being the sample size. The participant pool was even smaller in the follow-up, and this led to results regarding the 30-month period not being statistically significant. Attrition bias. It's possible that those who left the study had a bad experience, which could skew the data. There also was no control group, and there were multiple confounding variables. Some of those confounding variables included a high patient load and increased work demands, particularly at the 30-month mark, the COVID-19, staffing shortages, and the lack of availability of the respite room during the study. Individuals from other units came and occupied that room, so staff could not use it. So this led to the question, are the results valid? The data is not conclusive, and although there are some limitations, the results obtained at the 12-month mark serve as a valuable starting point for further exploration. This data establishes a strong foundation for a more comprehensive investigation into the effectiveness of Code Lavender. Results. Author conclusions. The author acknowledged the numerous issues that occurred in the implementation of this study. The study began in 2020 during the period of COVID-19. There were periods during this study when patient acuity and load increased. This was what was thought to impact the third data set, or the 2.5-year mark. However, the evidence on its effect on burnout and secondary traumatic stress was inconclusive. There were numerous variables that in some cases during the study prevented the utilization of the respite room. Future studies on a larger scale are necessary to evaluate the program's full potential. The program has garnered momentum in the hospital where they reside, and there has been an effort at the facility to incorporate it hospital-wide. Conclusion: the need to find a way to reduce nurse burnout among my nurses in the Pediatric Oncology unit is an urgent issue. The article, despite its many issues with sample size and confounding variables, provided an outline of a method to increase nurse well-being. The 12-month period of data, which was statistically significant for increased compassion satisfaction, piqued my interest. I am interested in pursuing a project like theirs. I want to provide my staff with a respite room and work to budget in a resource nurse to provide my nurse with the needed break. I will produce a box for which staff can anonymously write down desired qualities in a new program that I wish to develop. To discuss this project with management, I will need to gather data of my own. I will send out a survey to my staff, like the Professional Quality of Life questionnaire. I will analyze the data and use that in the initial part of my presentation. I will discuss the findings of this article and articulate the improvement at the 12-month period. From there, I will propose developing a respite room in one of the empty offices that reside in the unit. I will also highlight the need for additional personnel to provide relief on busier shifts.